Three, two, one. We are live now. Over to you, Dr. Manoj.
Uh, Good evening and welcome to this another edition of the Obstructive Airway Disease webinar series conducted by Dr. Sandeep Salvi, the president of ICS, and our ever dynamic Dr. Amita Nene, the chair at TEI, Indian Chess Society, and Dr. Rajadhar, secretary ICS. I must first thank the entire ICS community for inviting me to be the moderator of this webinar today. And first of all, I would sincerely invite you to participate actively in the NAPCON Pune, which is going to be conducted between 23rd to 26th January 2025 at JW Marriott Hotel, Pune. And all the senior faculty members from the ICS would be there. And we look forward to your active participation. And there will be a lot of encouragement for the younger colleagues who can showcase their talent in this prestigious event. And it's going to be a bumper show. And that is something that we can assure on behalf of Dr. Amita Nene. So starting with the proceedings today. So we are going to talk about something which is, has come up quite recently. I won't say too recently, but it is a recent event. Because we are having an exciting time about with the obstructive disease, which includes COPD and asthma. We have, several developments which have occurred over the last, decade. Started from the introduction of the biologicals, then phenotyping, and perhaps we are much wiser in treating these patients. And one of those interventions, it also includes the development of SIT, that is single inhaler triple therapy. But unfortunately, obstructive disease, which includes COPD and asthma, continues to be a leading cause of morbidity and mortality in India, despite all these advances. We all know that long-acting bronchodilators like LABAs and LAMAs are the cornerstone in the management of COPD. And ICS LABA play a vital role in the management of patients with the asthma. So when we talk of the triple therapy, it actually includes a combination of ICS, LABA, and LAMA. And as per the gold guidelines, we all know that the triple therapy would be indicated in symptomatic patients of COPD who are on dual therapy and who are at increased risk for frequent or severe exacerbation. Similarly, add-on LAMA is recommended in uncontrolled asthma patients on medium to high dose ICS LABA by the GINA guidelines. So when we talk of the triple therapy, when we in case of COPD, when we add ICS to dual bronchodilator therapy, we say it's a triple therapy. In case of asthma, when we add LAMA to the ICS LABA combination, then we say it's a triple therapy. And this is something which is evolving very fast in our practice. We also know that symptom burden and exacerbation are common amongst the patient with obstructive airway disease. And the main cause for this symptomatic burden and exacerbation is the poor adherence to inhaler therapy, which is the most frequent challenge in our day-to-day practice. And to address this issue, SIT is one of the better treatment options, which can optimize symptom control, improve quality of life, reduce exacerbation risk by improving the desired adherence to inhaler therapy, which remains a cornerstone in the management of obstructive airway disease. So today we aim to provide an expert review on the use of single inhaler triple therapy, that is SIT, for obstructive airway disease, primarily for COPD patients, especially in Indian setting. And we have an excellent panel to discuss this important issue today. And let me first introduce our speaker, who is a very learned, knowledgeable speaker, Dr. Anshum Aneja Dang, who is from my own city, that is Gurgaon. And she, in fact, doesn't need any introduction. She is highly qualified, MBBS, DTCD, DNB, has got various fellowships, has done diploma in adult respiratory medicine from Munich, diploma in pediatric sleep medicine from University of Colorado. She's senior pulmonologist, in fact, one of the senior most pulmonologists in the city of Gurgaon before, the other corporate hospitals came up like Medanta, the Artemis and Fortis. She was already there practicing. And she has shown us the path of development of pulmonary medicine in the city of Gurgaon. She's currently working in her own setup, that is Aero Health Gurgaon, as a senior pulmonologist. And she's also visiting prestigious hospitals like CK Birla Hospital and Verizon Hospital in Gurgaon. She is an icon in respiratory physiology. She is well known for her research in oscillometry. And if you've got anything to learn about oscillometry, she is the person you can just talk to. She has special interest in sleep disorders. She's got her own sleep lab in her center and has been working with the pediatric sleep medicine, which is sort of a niche branch for the pulmonologist. She has been member of various national international societies. So I would request Dr. Anshum, who is perhaps the best person to talk about this topic of the single inhaler triple therapy. May I please invite Dr. Anshum Maneja?
Thank you so much, sir. You always been so generous with the praises, and it's indeed very heartening. Thank you so much for all the affection. So I'll share my slides now, and at the outset, also thank Amita Nene ma'am for inviting me to speak here on this prestigious forum. So I hope my slides are visible.
Yes,
Yeah.
yes.
All right. Okay. So, so sir has beautifully outlined, I would say, and introduced today's topic and how this has been a real landmark in the management of obstructive airway disease. Single inhaler triple therapy, as we know it, has been available for last few years, but has really escalated and it's being utilized in more and more patients, and patients are benefiting from it. um, I think most of the seniors here would agree that the whole landscape of management of obstructive airway diseases, especially COPD, has changed ever since we've had combinations like single inhaler triple therapy. So when we started practicing COPD in the past, and we used to probably just have salbutamol, ipratropium, SAMAs to deal with the symptoms of the patient, and we really had nothing to improve the quality of life per se. But things have changed since we entered this century, and we have longer acting drugs. We now have ultra long acting drugs, and the single inhaler containing all the three drugs, the ICS, LABA, and LAMA, has actually been available with us right from 2017. It's only recently that it has gained so much of momentum because we have it's backed by powerful landmark trials which have shown effect not only on symptom quality but also on mortality benefit, which is something that's of great importance for a patient with COPD. So, if we talk about the approved triple therapy ICS LABA LAMA, US actually just has two molecules approved for triple therapy. One being vilantrol, meclidinium, and fluticasone, and the other being extra fine beclomethasone, formoterol, and glycopyrronium. We in India are actually lucky to have many more combinations at our disposal where we can choose, pick and choose between once daily to twice daily therapy and between the devices that we can offer to our patients for triple therapy. But when you have more choices, you also have more confusion. So if you look at this slide, which I've carefully collected all the available triple therapy combinations available to us in India, you'll see that there is a great variability between what we have in terms of the strengths of whether it is the LABA or the ICS or LAMA. Between various pharma distributors, there is a difference between some having more of inhaled corticosteroid components, some combinations having a different strength of LAMA. So we really have more choices to pick, to choose to give a lower dose or a higher dose of ICS that we want in a particular patient. And although vilantrol, fluticasone, and umeclidinium is one of the most popular combinations available in US and Europe, in India, in addition to that, we also have triple therapy with budesonide, formoterol, and glycopyrrolate, which is a very convenient and highly available combination, given that the combination of formoterol and budesonide is already so frequently used. So it's easy to just add on another component and give the patient triple therapy. So, with that, it's important to understand that which patient would merit which kind of medication and which combination, because as you know, that the doses may vary. So, it's not just about the molecule, it's also about the strength that it has in that combination. So, you need to be aware whether the dose would be a puff a day, twice a day, or two caps a day, and so on. So, when we manage COPD, we know that the cornerstone of managing COPD across the phenotypes, if we would want to give precision medicine, would be a LABA, and that too a muscarinic antagonist, an anticholinergic drug. That would be our universal and probably the first step in which a symptomatic patient would be managed for COPD. Addition of extra drugs like inhaled corticosteroids, mucolytics, anti-inflammatory drugs, they would depend on the phenotype that we're dealing with and the primary problem that the patient is facing. So when we talk about combining these various molecules together, we're actually talking about achieving better response as compared to one molecule over the other. So when we add a LABA and a LAMA in a COPD, we're actually looking for a synergistic interaction where 1 plus 1 is not 2, but rather is 11. And that's exactly what we achieve when we step up our patients from a single bronchodilator to a dual bronchodilator. And COPD being a disease involving the small airways predominantly and the periphery of the lung, what's also very important is for the LABA LAMA combination to reach the peripheries and also act there. By combining LABA and LAMA together, we achieve not only changes in the dyspnea scores, improvement in the FEV1, but also alteration of the mucus overproduction and also get an anti-inflammatory activity. So best of both together. But then what is the rationale of adding triple therapy for a patient with COPD who already has good bronchorelaxation with the addition of LABA and LAMA? So, when we add an inhaled corticosteroid in COPD, the target here is to suppress the eosinophilic inflammation. The target is to manage increased exacerbations. And with that added to the LABA and LAMA, which has already exerted a good airway dilatory effect and an anticholinergic effect, we attempt to elicit a very strong synergy and smooth muscle relaxation. So it's important to understand that adding ICS to a patient with COPD would be in an attempt to improve the exacerbation rate and to suppress the eosinophilic inflammation. With that in mind, we have to remind ourselves that gold guidelines have persistently been vocal of specific scenarios where you would add ICS to a LABA-LABA combination. So when we're talking about triple therapy, it's important that the patient selection takes care of this scenario wherein an ICS would be beneficial to a patient so that we have a benefit which will outweigh the risk. The gold guideline suggests that a patient who is having multiple hospitalizations, more than one severe exacerbation, or more than two severe exacerbations, along with a blood eosinophil count of more than 300 or a history of asthma, would be an ideal candidate where ICS could be added to the regimen. They do give us some leverage in patients who do not have more than two moderate but have more than one moderate exacerbation a year and blood eosinophils at least 100 cells per microliter. This essentially tells us that the role of inhaled corticosteroid in the combination is essentially in patients with more exacerbations, hospitalizations, and eosinophilia. If a patient has eosinopenia, probably he will not benefit by the addition of ICS, and so triple therapy may not be the ideal for that patient. So essentially, if we need to break it down, then amongst the COPD phenotypes, those phenotypes who would do well with an ICS plus LABA-LAMA combination would be the ones with asthma, would be the ones who are frequent exacerbators, the ones who have a rapid decline in lung function, and element of eosinophilic inflammation. These would be those phenotypes, along with the ones who are more symptomatic due to hyperinflation, that an ICS LABA LAMA or a triple therapy combination would work well. So, the GOLD guidelines stress that when you start initial pharmacological treatment of a patient, then ICS plus LABA LAMA is reserved to group E. That essentially also tells us that it is reserved as a step up therapy and probably should not be the ideal first line therapy in most of our patients. It also means that, according to the GOLD guidelines, we need to ascertain when our patient has more than two moderate exacerbations or a severe exacerbation and has blood eosinophilia more than 300 to classify that this patient would benefit with LABA, LAMA, and ICS. This is something that may bring issues in the real world scenario. When a lot of times we diagnose a patient who comes to us for the first time with an undiagnosed COPD, with repeated exacerbations that were often not reported, or patient coming up with the first PFT in our hand telling us that the lung function is severely impaired. Hence, LABA, LAMA, and ICS, the role of the triple therapy together has to be further evolved and further investigated. Definitely, when we're managing a patient on follow up, the role of LABA LAMA ICS is well established. And especially the guidelines here give us a leverage that even if the blood eosinophil counts are more than 100 and the patient is continuing to have exacerbations despite a LABA plus LAMA, we could add an ICS component even if the eosinophils are not crossing the threshold of 300. So, how do we get these results and how do we get these interpretations? But this comes from certain landmark studies that have taken place over the last 10 years. There have been numerous papers on triple therapy and essentially single inhaler triple therapy over last many years. The whole idea of giving a single inhaler triple therapy is not because a single inhaler triple therapy would be more efficacious than multi inhaler triple therapy or open triple therapy, but rather the convenience, the ease, and the compliance in a single inhaler would be much more. The basis is essentially combining the triple therapy and all the three drugs together. So if you look at this slide, I have enumerated the major studies that have been done on triple therapy across the globe. Most of the studies in the US have looked at the combination of vilanterol, imiclidinium, and fluticasone furoate versus a LABA-LAMA or versus an ICS-LABA. We also have studies on extra fine beclomethasone, formoterol, and glycopyrronium. And amongst all the studies, there's actually only one study that has looked and directly compared a a triple therapy, which is single inhaler, versus an open triple therapy. Hence, essentially, the studies, all of them, have really given more insight into how combining the three drugs together in the right patient can reduce exacerbations, can improve the quality of life, and can also improve the FEV1 score. So, this is a meta analysis that was published in 2021 that looks into four of these major RCTs. And it shows that if you look at the ICTs that are done for triple therapy, all of them show a favorable response in number of exacerbations. Most of the patients that have been enrolled in trials have been those with moderate to severe COPD. Patients who've had more than two moderate exacerbations in a year, and patients who also have an eosinophil count which is around 150 and above. So, if you look at the data with these group of populations, most of the studies have reported a favorable response with triple therapy as compared to dual therapy in such a COPD population. When you look at the effect of mortality, which is another very important aspect, which is not usually the outcome which is measured when we talk about individual drugs, the effect on mortality is one of the greatest effect with triple therapy. In fact, the GOLD guidelines mention single inhaler triple therapy as one of the only pharmacological interventions that can affect mortality. And all across the studies done, the mortality benefit has been seen, whether indirectly as a post study cohort analysis or as a part of a subgroup analysis. It's also been shown that addition of triple therapy in the right patient population can result in an effective change in the quality of life, something that is really important, especially for the group E patients who are already suffering so much at the hands of severe COPD. They've also noted, and I would repeat unanimously, all studies have reported a higher incidence of pneumonia on addition of ICS to the LABA-LAMA combination. But they've also clarified that it still remains a more preferable treatment in patients with symptomatic, moderate to severe COPD with history of exacerbations and is superior to LABA-LAMA because of the lower incidence of exacerbations and the outcomes because of that. There have also been several meta analyses that address the concern of extra pneumonia or extra incidence of pneumonia in patients on triple therapy. And although the incidence of pneumonia has been higher in the ICS group, there hasn't been a very strong direct causality link. A lot of patients who have exacerbations do have infective exacerbations and could also have pneumonia as a result. So, when you look at this forest plot, it essentially shows us that the results are mostly equivocal. There is no significant difference in the pneumonia incidence between patients on dual as well as triple therapy, even though the incidence of pneumonia has been found to be high in the triple therapy group. Also, the combination has a favorable risk profile in terms of cardiovascular disease, which is a very important comorbidity that one has to look at. With that, it's almost very logistic to understand that if a patient benefits with triple therapy in the most severest forms of COPD, he would benefit and prefer a single inhaler over multiple inhalers because the compliance, the ease of use, the reduced overall costs of multiple inhalers, and the confusion attached to it is addressed. So, Gold definitely recommends that if you have to give multiple inhalers, it's better to combine them into a single inhaler rather than give them different inhalers. There's been only one major study that has essentially looked at a direct comparison of a single inhaler triple therapy with an open triple therapy or a multiple inhaler triple therapy. The Trinity trial that I'm referring to has, although matched and compared extrafine beclomethasone, formoterol, and glycopyrronium with an open triple therapy with tiotropium. So essentially, even this is not a direct end-to-end comparison. So the benefit of giving a triple therapy in most patients would be in single inhaler as a result of more compliance and better ease of using a single inhaler. The study has reported almost equivalent efficacy whether a patient is on an open triple therapy or a combined triple therapy. And many research trials over across the globe have reported better patient persistence along with better reduction in the risk of exacerbations and mortality with the use of single inhaler triple therapy as compared to giving them multiple inhalers. So that brings us to a question that what will be the ideal timing for triple therapy? Because if we go by the guidelines, then the ideal would be as a step up to a patient who's already had multiple exacerbations. There have been several studies that have looked at whether one should initiate triple therapy promptly or later after observing the patient. This is a retrospective analysis which was published in 2023, which looks at the initiation of a triple therapy inhaler after a delay after the index moderate exacerbation or the first severe exacerbation. They noted that if you delay the initiation of triple therapy, even after one severe or two moderate exacerbations, the risk of exacerbation exponentially goes up as you delay it. In fact, every 30-day delay in the addition of budesonide, glycopyrronium, and fluticasone in this combination, formoterol in this combination, was associated with a 5% increase in COPD exacerbation and thus a 3% increase in healthcare utilization. Another group in the Primus study in US asked a question whether we should wait for two moderate and one severe exacerbation or rather start the triple therapy once we have any significant exacerbation. And they found that if you delay a patient's initiation on triple therapy after a severe exacerbation, then as you delay with the number of days passing, the healthcare utilization and the severity of exacerbation may be higher. So they conclude that a prompt initiation may reduce the risk of future exacerbations and reduce healthcare utilization and costs. So we could consider a triple therapy even after a single severe exacerbation to decrease overall patient morbidity. Now, when we talk about prompt initiation, a lot of people will criticize it by saying that one should de escalate ICS as much as possible. And this has been studied in several studies who've looked at a withdrawal of inhaled corticosteroids versus continuation of inhaled corticosteroids in triple therapy. In such a scenario where one would want to start triple therapy as soon as possible, there should be a scope of also de escalating the patient because it's believed by many people that triple therapy is a one highway, is a one sided highway. Once a patient is on triple therapy, he probably will not tolerate reduction in ICS. However, data has shown that in patients who are carefully selected subgroup of patients who have probably infrequent exacerbations, one can actually withdraw inhaled corticosteroids without an excessive increase in the risk of exacerbation, where the control group has 47% risk of an exacerbation in a year, and the group which has an ICS withdrawal has a risk of around 52%, something which is not very highly significant. In the DACOD real world study done in US, they again looked at switching triple therapy back to dual therapy. And they concluded that if you look at eosinophil counts only as a marker of escalating or de-escalating triple therapy, you will not be able to correlate it very well with the symptom score or predicting the subsequent outcomes. So, in a physician identified um, patient population where the patient is better, the exacerbations are not frequent, there should be an option and it should be possible to de escalate the patient back to dual therapy. With that, it's also important to realize that no matter how good your molecule is, the devices really determine how the agents are delivered. So, when we talk about single inhaler triple therapy, one has to remember that most of the studies or most of the landmark trials that have been done on single inhaler triple therapy have used devices which have been patented devices. Talking about the Cronus and the Ethos trial, PMDI with co-suspension technique has been used. If we talk about the IMPACT trial, which is the largest trial on single inhaler triple therapy with more than 10,000 patients, the Ellipta DPI device has been used. And we talk about the Tribute study, extra fine formulation in a PMDI has been used. So it may not exactly be possible to have those results which we are seeing in the RCT in the real world scenario. And so it's also important to consider better devices when we're talking about triple therapy. And it's time that the pharmaceutical companies also take more note of advanced devices which are available globally where the drug deposition could be enhanced. The co-suspension technology that I've mentioned about triple therapy, and in fact has been used for most of the trials on budesonide, formoterol, and glycopyrronium in the States, utilizes a specific porous phospholipid which binds individual components of the drug, resulting in better drug delivery. They've also reported that if you compare a conventional PMDI versus a co-suspension MDI, then the drug reposition will be uniform throughout the course of treatment. So, this is also important to realize that the drug is as important as the device, and a conventional MDI with triple therapy or a conventional DPI with triple therapy may still have a lesser efficacy than a better device. Lastly, one should also discuss about eosinophils and triple therapy because eosinophil criteria is one of the most pronounced criteria that the guidelines have given us. If you look at the landmark studies of triple therapy versus dual therapy in COPD, you would see that most of the studies have a median eosinophil count of 150 above in all of their arms, showing us that the patients who have benefited with triple therapy are essentially, though irrespective of the absolute number of eosinophil, have been ones who have a consistent or a prominent eosinophil concentration more than 150. In fact, the Ethos trial, which is the major trial which talks about mortality benefits with triple therapy, also has a subgroup analysis based on the eosinophil count and shows that if you talk about eosinophil counts, then irrespective of the eosinophil count, triple therapy does show a favorable response. But the higher the eosinophil counts, the response is much better. So definitely it paves the way to understand that the right patient you would select for triple therapy, if he has a high eosinophil count, the benefit of adding ICS to the combination would be manifold as compared to a patient who has a relatively lower eosinophil count. With that, there have been recent expert reviews, not only from India, but also Delphi consensus statements which have been published with experts from more than 10 countries who've reviewed all the data about triple therapy. And most agree that single inhaler triple therapy becomes a viable option for patients after discharge, after severe exacerbations, and patients who are not controlled with initial management. So then let's summarize who will be an ideal candidate for triple therapy. If we talk about single inhaler triple therapy, according to the guideline, the ideal candidate would be a gold group E patient who has high symptoms, high risks of exacerbation, low lung function, and moderate to severe exacerbations. Is it irrespective of eosinophils? Not absolutely. But is it only 300 cell count? Studies have shown that the effect is also there if the eosinophil count is above 150, but definitely much more above 300. Another candidate for SIT would be a patient who has to escalate therapy after LABA/LAMA or ICS/LABA, and you can also do that after a patient has an acute exacerbation and is discharged probably till symptomatic control. COPD-A definitely remains as one major indication, and even non-smoker COPDs are an important indication. And out of guidelines, you would probably be able to switch patients with inhaler issues, compliance issues that are not taking multiple inhalers to single inhaler triple therapy to get a better response. But before you consider escalation of a patient to triple therapy, it's important to recheck your device, the compliance, other comorbidities, smoking status, pulmonary rehab, and other roles. Step down is important when we talk about a patient with ICS, but if you're talking about a patient who uses oral corticosteroids more than 1 to 2 times a day, who has multiple exacerbations, and has eosinophil count more than 150, probably a step down may not be necessary. But if a patient has infrequent exacerbations, patient just came with one severe exacerbation and has been stable all through, probably that patient deserves a step down. The ideal duration is something which is a matter of debate. Some studies, some papers mention months and try to step down in 3 months. Some mention 18 months, some mention a year, and some mention it may not be possible and maybe a unilateral highway. We still need more data to ascertain that. When do you sit as a first line treatment? According to the guidelines, you would do that when you get a patient who's had multiple exacerbations, high eosinophilia, and symptomatic profile. I would do that probably post discharge for a patient with an acute severe exacerbation and not send him home on just a LABA/LAMA. And definitely would do that in patients where benefits outweigh the risk of pneumonia and infection. With that, I would conclude my slides. Thank you very much for the patient hearing. So you're mute. So you're mute. Yes.
Thank you, Dr. Anshu. It was excellent and flawless as usual.
Thank you, sir.
You have dealt with the topic quite extensively. It was an elaborate, comprehensive, to the point, and crisp review of the triple therapy in the emergency OPD, especially the single inhaler triple therapy. So I really thank you for this wonderful talk, and you deserve a lot of accolades for that.
Thank you.
So before I move on to the panel discussion, let me introduce the eminent panelists that we have on board today. So first of all, it's my pleasure to introduce Dr. Idrili Halder, who is a great friend of mine. He's an associate professor and head of the Department of Pulmonary Medicine, COM and JNM Hospital, West Bengal University of Health Sciences, Kalyani. He's MBBS, DCH, MD Pulmonary Medicine. He's done FRCP from Glasgow, has got a European diploma in adult respiratory medicine. And he's been faculty of National Allergy, Asthma, Bronchitis Institute, Kolkata, Regional Faculty of Public Health Foundation of India. He's ex-East Zone Chairperson of Indian Chess Society and Chairman of State Chapter of Indian Chess Society, member of the governing body of ICS for several years, invited speakers at different national and international conferences, has got a number of publications, and is a renowned pulmonologist, academician, and is master and truly a class in his stature. So I welcome Dr. Idrili Halder. It's really an honor to have you on board today.
Thank you. Thank you.
Next, I would like to introduce Dr. Parul Vadgama. She's professor and head of Department of Tuberculosis Chest, Department Government Medical College, Surat. She's Executive Council member, Veer Narmad, South Gujarat University, 2024 to 26. She has been the Joint Secretary of IMA, Akin Sinha, between 22 to 24. She has been the Public Health Committee Chairman, South Gujarat Chamber of Committee, Commerce and Industry, 23-24. PG and PhD guide in the field of respiratory medicine. Past President of IMS Surat, 2019-2020. invited speaker at many state level and national level conferences, several publications in national and international journals, past vice president IMA Gujarat state branch, conducted 2 state level tuberculosis conference in the capacity of organizing secretary. So she has played an active role in the IMA in the pulmonary medicine. I really welcome you, Dr. Pal Vadgama, today on this board. Thank you very
sir.
much.
Thank you. Thank you very much.
Next, I welcome Dr. Anita T. Anokar. She is DNB Respiratory Medicine and has got a diploma in critical care medicine from Indian Society of Critical Care Medicine. She is a consultant pulmonologist and intensive care specialist. She is associate professor of respiratory medicine at BYD2UMC Pune and has got areas of interest such as interventional pulmonology, lung cancer, occupational lung disease, pulmonary fungal infections, airborne infection control. Welcome, Dr. Anita T. Anokar. Your presence is very crucial and vital for us. Thank you so much.
Thank you, sir. Thank you, sir.
And I also feel very happy to introduce Dr. Anand P., who is DTC DNB, European Diploma in Respiratory Medicine from Switzerland. He is MNMS, FCCP, and FA PSR from Japan. He's a professor of Department of Respiratory Medicine, Vellamal Medical College, Madurai. Senior consultant interventional pulmonologist at BMC Specialty Hospital, Madurai. Consultant in chest clinic, Ramanathapuram. Consultant PR chest clinic, Madurai. He has got several degrees, DTC, DNB, and European Diploma in Respiratory Medicine. He is the founding member of SPICE, Vice President, Madurai Respiratory Society, Indian Society, Indian Association of Bronchology, National Academy of Medical Sciences, European Respiratory Society, Association Diplomat of National Board Doctors, Association of Pulmonologists, Tamil Nadu, Pondicherry. So is very, very active in the development of field of pulmonary medicine. He has several awards, Young Scientist Award from Indian Society in NAPCON 2010 at Jodhpur, first prize in quiz competition, CAPCON, and he has a number of international presentations. I welcome Dr. Anand P. today.
Thank you, sir.
Important session.
Thank you.
And I would also like to thank our coordinator, Aditi Vaidya from Imagica, who has been providing us the logistic support. And all this has been made possible by her efforts. So with this, I welcome you all with folded hands and look forward to a nice, very educative, interactive session today.
So Manoj, it's my responsibility now to introduce you and practically who really don't require any introduction, but he is the principal director and head of pulmonary critical care and sleep medicine of Fortis, Gurgaon, Delhi. So he is not only a pulmonologist, but an interventional pulmonologist, a master in trainer in EVAS. So he was an author and editor of bronchoscopy in the ICU, organizing secretary of our NAPCON 2023, Oration Awards, their number of publications, and most important, he was the principal investigator of 2 important publications which was published in Lancet and also in the NEGM. So with this, I will be requesting Manoj to again highlight the NAPCON 2024, which will be held on 23rd to 26th January 2025 at Pune. And it is my earnest request as one of the governing body members of the ICS, please be there. It will be a very academic feast and we'll all enjoy the academic feast there. So thank you, and over to you, Manoj, again.
So once again, I invite you to the NAPCON 2024, and not for 1 day, not for 2 days, but all 4 days. That's must, very important. And it'll be very nice to have you all there with you and with all your colleagues. So now I think we can move on to the panel discussion. And once again, I thank Dr. Anshum for, summarizing all the aspects of triple therapy in the management of COPD patients. And but my first question goes to Dr. Indranil Haldar. Dr. Anshum has, described about the evidence and efficacy of safety. But are you satisfied and happy with the current evidence of efficacy safety of the triple therapy?
So Angsu has done a real great job in putting forward all the trials that are there, majority of the trials that are there with triple therapy in COPD patients. So overall, if you compare the LABA ICS LAMA versus LABA LAMA, triple therapy, I am telling the bottom line, Angsu has done a great job. It decreases the risk of exacerbation. It improves lung function, health status with a favorable benefit to harm ratio. Not only that, triple therapy showed a promising sign in terms of improved survival. So all evidence suggests that triple therapy is more effective in moderate to severe symptomatic patients of COPD who are at risk of exacerbation with marginal, if any, risk of side effects, which includes pneumonia. So there are ongoing studies still. The role of triple therapy in less severe symptomatic patients with asthma, COPD overlap, that with now the terminology has been withdrawn, and with patients of COPD. So the bottom line is, yes, it is beneficial. Toxicity probably similar in that way.
So, Dr. Indraji, actually, all these trials have shown that triple therapy is superior to dual therapy. But, there has been criticism about these trials. Criticism is in the sense that, the majority of these patients, in fact, many of these patients were having pre-existing asthma in these patients. So, asthmatic component was quite pronounced in these patients. Many of these patients, in fact, had, frequent exacerbation, maybe moderate exacerbation in the past, even though they may not be very symptomatic. So, would you like to elaborate on that a little bit?
So every trial that has been shown has some sort of conflict of interest, because again, you see the GSK trial with Uniclinium and others trial, there are definite conflict of interest. So if you subgroup analysis, again, as you told, Manoj is right, that there were patients who were there with the asthma component. But again, if you see the others trial or meta-analysis that has been done, there are a lot of meta-analysis with a lot of a huge number of patients which has been shown. For example, what I did from literature review, there are 5 published articles with 6 clinical trials. We screened more than 3,000 articles with a total of more than, say, 4,000 or something more patients with separate and clinical trials with triple therapy versus dual therapy. And overall, their implication was that compared to triple therapy, single inhaler therapy appeared to improve the lung function in majority of them, and that were in moderate to severe COPD. So ultimately, the bottom line is, yes, in patients with moderate to severe COPD, and but real world setting has to be seen, and there are some studies which has also seen the real world setting in COPD patients which has been treated with ICS 9 plus with ICS in single inhaler triple therapy, and there were similar results. So there are conflict of interest, but the bottom line should be that yes, the more benefit than the dual therapy or in separate inhaler therapy.
The other aspect, Dr. Indraji, is that, there's a lot of talk about the risk of pneumonia in these patients. And, it's very much prominently highlighted. And one of the contraindications for using the triple therapy is the risk of pneumonia. But as a matter of fact, the risk of pneumonia may be 1.25 times, maybe 4% maximum that is reported. But patient can have pneumonia, but there is no data to suggest this is so increased mortality if the patient develops a pneumonia. Would you like to comment on this a little bit?
See, it is, again, in patients of COPD, the risk of pneumonia is there. But as Angshu has really shown that in patients who are having pneumonia, that should be avoided. In patients where the eosinophil count is more than 300, definitely it is indicated we can be starting with them the inhaled corticosteroid either as a triple therapy or as a separate inhaler. But that is treatable again, and with the role of vaccination, and the incidence of pneumonia has practically decreased. And as you told, the percentage is not that very high, which is hyped in spite of the fact that with steroid, the chances of pneumonia is there. But if the awareness is there and that the vaccination is there, probably the incidence will be decreasing, and also that it can be treated at the earliest when it is found.
Absolutely right. So I think you have set the ball rolling, Dr. Indraji Haldar. It was a wonderful speaking to you, and we'll have you on board again. So as I understand, the CIT is associated with increased risk of pneumonia among COPD patients when compared to dual therapy of LABA/LAMA. But this is irrespective of the type of ICS. So it is not that the fluticasone would have a higher risk of pneumonia as compared to budesonide. It is irrespective of the type of ICS. However, the rate of other serious adverse events or cardiovascular events are similar between CIT and LABA/LAMA therapy or the ICS/LABA therapy. And as you correctly said, there is strong evidence at this point of time to suggest that triple therapy is superior to the dual therapy. and is likely to improve the outcome and the mortality in patients of COPD, especially where it is really indicated. Now, my next question goes to Dr. Parul Vadagma, and again, Dr. Anshum touched upon this topic very beautifully. Still, we would like to learn from you, Dr. Parul Vadagma, when to step up to sit therapy and when to step down. I know it's not very easy in real world scenario, especially stepping down, but we would like to have your insight on this aspect, which is extremely important as a matter of fact.
Yes, sir. See, basically, we all know, sir, being clinicians, that step up and step down therapy, apart from the guidelines, is always a clinical scenario also. See, what guidelines tell today, that we all know that step up is done when there is a patient of COPD having frequent exacerbations, means more than 2 exacerbation or 1 hospitalization, MMRC more than grade 2, means CAT score more than 10, MMRC more than 2, or frequent exacerbations, patient not control on LABA plus ICS or LAMA-LABA. Apart from that, if patient is clinically deteriorating or patient's quality of life is deteriorating, or patient's eosinophil count, blood eosinophil count is more than, some guidelines say more than 300, and some of the times when it is already on LABA plus LAMA, it can, if it is more than 100 also per microliter, then also we consider this patient for starting or step up of the triple drug therapy in single inhaler for a COPD patient. Now, if we talk about, the de-escalation, whatever means, which is very important and critical, there has been many studies, and especially in Spain also there has been one study for de-escalation of the therapy, where they tell that if the patient has, if the patient's COPD with less eosinophils increase or no eosinophilia, in such cases, or a patient who is having first time exacerbation or in the first year of therapy, we can think of decreasing or removing the ICS from the therapy. Similarly, it is not a thumb rule. Similarly, the patient of ACOS having some asthma component or some eosinophilia, we can think of removing the ICS. And patients who are having first time exacerbation but not frequent exacerbation, or clinically they are settled patients, in such cases we can think of de-escalating the therapy. But there is as such not a thumb rule for de-escalation, but these are some guidelines, or not, I would not say guidelines, but there are some trials in Spain and some of the countries which tell like that in such cases we can de-escalate.
Thank you, Dr. Parul, for your insight. And if I want to summarize to this point, possibly patients who are symptomatic, who are not controlled on LAMA or dual therapy of LABA-LABA, and those with frequent exacerbation and high eosinophil count should be stuck to triple therapy. The current guidelines recommend triple therapy for severe disease, frequent exacerbation, persistent symptoms, who are not adequately controlled with LABA-LAMA combination. However, several real-world studies reported progression to triple therapy even in patients with no exacerbation in the previous year. This is something which is tricky. So when we talk with the group E patients, we have absolute clarity. But here, in real world scenarios, we do find the patients who are symptomatic, who continue to be symptomatic without exacerbation in the previous year, where the dyspnea seems to be the key driver, where the change to TT is done. And this is very well shown in the real world studies. As far as the de-escalation is concerned, the de-escalation from triple therapy is attributable to either lack of efficacy. Suppose the triple therapy has not worked for the patient, and the patient, on the other hand, starts developing complications such as pneumonia. Or if the patient who has got a disease which is now effectively controlled, stable with triple therapy for a significant period of time, which may possibly vary from patient to patient, depending on past history of exacerbation. And as Dr. Ashram said, if there is only single exacerbation, possibly you can de-escalate maybe in few months' time, but somebody who's got a history of several exacerbations in the past, possibly it will be very difficult to de-escalate from the triple therapy in these patients. The current guidelines also propose safe withdrawal of ICS in patients with stable COPD, particularly non-exacerbators with low blood eosinophil count, as Dr. Parliu very rightly said. So now my next question goes to Dr. Anita. One of the key development in the recent years over the last decade is the role of biomarkers. We were aware of these biomarkers, but these biomarkers was not so much applied as now they're being applied. In fact, now when we talk of COPD and asthma, we first talk of biomarker. First, the patient who comes to my OPD or your OPD, you would like to do an IG in this patient, like to look for the eosinophil count. This is becoming a part and parcel of today's management in COPD. So, what do you think is the role of biomarkers in single triple therapy, Dr. Anita?
So definitely the role of biomarkers has been every time we talk about biomarkers, but really talking about when to add about the single linear triple therapy, or basically it is the addition of LAMA to the ICS LABA in case of asthma, where in case of persistent symptoms or uncontrolled asthma, it is already in the guidelines, like without any biomarkers is more than 12 years of age, we have to consider those triple drugs. Same thing for considering in COPD cases, like we are already giving LABA, LAMA, and there is a concern about the ICS addition, which is already stated in the GOLD guidelines. But still, if we want to specify the specific biomarkers, then we can divide it into terms of like clinical, that is exacerbations are taken as a clinical biomarker. Then there is something like a physiological biomarker, that is poor FEV1 or blood eosinophil count. So blood eosinophil count, Dr. Anshu has already stated, like it is given more importance than sputum because it is not readily done. So more than 300, obviously there is a shown to be benefit, but for consideration of addition, we can consider more than 100 for the inclusion. Then there is another biomarker that is taken as a therapeutic, whether this will be therapeutically useful for that patient after the addition, even if all the other parameters are there. So that is related to the use of device or something called as peak inspiratory flow rate. So even if you consider the device or patient's inhalational rate, whether will be able to use that. So that is something added as a therapeutic biomarker. So you have to take into consideration while considering which device, which molecule, along with that, whether patient is able to inhale that with peak inspiratory flow rate. So like we have that for dry powder inhalers or meter dose inhalers. So while choosing the inhaler device and the molecule, that we have to additionally consider this.
I think wonderful, Dr. Anita, and you talked of various biomarkers which are not the traditional one, and highlighted how important that we have to look into various aspects of the management of COPD and asthma patients. But all of us are quite intrigued with actually eosinophil counts, and as for the also there is play a lot of stress on the eosinophil count. So I would like to discuss a little bit of the eosinophil counts and how sort of drive our management of COPD patients. So it's clearly shown that the ICS treatment reduces exacerbation rates in COPD patients with higher blood eosinophil counts. So higher the eosinophil counts are there, the chances are that the ICS are going to be beneficial in these patients. And the withdrawal of ICS treatment is associated with an increased exacerbation risk only in patients with elevated blood eosinophil count. So again, this could be a big driver of the exacerbation. So if there is high eosinophil count, again, it's very difficult to de-escalate these patients from triple therapy. The other thing that is quite common in our country is the non-smoker COPD because of various reasons, as we know. And what we have found that in majority of these non-smoking COPD patients, again, the eosinophil count is high, and therefore these patients might respond better to ICS treatment. So this is one of the biomarkers. The non-smoker COPD possibly is one aspect where the triple therapy could be useful. And one interesting thing which is there is that it has been observed that the pneumonia risk following ICS treatment is lower among patients with high blood eosinophil count. So if you're using ICS in patients' blood eosinophil count which is high, the chance of pneumonia risk is less as compared to other patients of COPD. So actually, eosinophil is a very fascinating subject in the management of, or in the diagnosis and management of COPD and asthma patients. So coming
I'd
to
like to add about this pneumonia risk. Like it is already shown that there is a low risk compared to this thing. Plus, there is all-cause mortality is less when patient is on this SITT compared to two drugs inhaler. So if it is reducing all-cause mortality, so the overall benefit and risk of hospitalization, poor increase in lung function, that is helping in already the reduction in risk of pneumonia. So this risk of pneumonia has been observed more in patients with poor lung function and low BMI compared to the other categories. So it is not to be like much worried about if you are monitoring closely the patient and if it is benefiting him.
Absolutely. So actually, this risk of pneumonia has to be in our radar all the time. And we must be watching these patients for any of these symptoms. If it happens, and in fact, if somebody who's got a recurrent pneumonia, recurrent chest infection, right? It is less not pneumonia. What I believe somebody is developing respiratory, lower respiratory tract infection, fever, increased mucus production, purulent secretion, purulent sputum. And he's coming back to, with several times with infective exacerbation, then possibly again the triple therapy may not be the useful idea in these patients. So now coming to my next eminent panelist, Dr. Prem Anand. Again, something which is very important to discuss. What should be the frequency of single-inhaled triple therapy, once or twice? What is your choice, Dr. Prem?
So it all depends upon the LABA, LAMA, and ICS used in the various combination. In India, we have two types of combination. That is, one is formoterol based. Usually, formoterol based are better to be given twice a day. It may be either formoterol in DPI form, whatever. And for once daily, we have intercatal based DPIs, vilanterol based, etc. So it all depends upon the molecule being used. So if it's formoterol, we have to go for twice. And if it's intercaterol, vilanterol, etc., once a day will do. And regarding COPD patients, as we all know that SIT therapy has been superior to when switching over from multiple inhaler triple therapy or even dual therapy. There is chances of more adherence and persistent to treatment with SIT. So altogether, SIT is far better when compared to twice a day. But when you go for a formoterol based options, it is better to go for twice a day. And regarding COPD patients, some of them may present with nocturnal symptoms. So in those patients, we may need twice a day. In that case, better to go for a formoterol based.
So I totally agree with you. In fact, actually, this has to be patient oriented. We have to see what is the symptomatology of the patient, which time the patient is more symptomatic. So round the clock symptom control is COPD is the key, right? The patient should be symptom free as much as possible. Now, sometimes, in fact, many times the patients with nocturnal early morning symptoms burden, right? In these patients, you would possibly go for a twice daily dosing, which will be beneficial in these patients, which will take care of the nighttime or the early morning symptoms. However, there is other part to it, other aspect to it, that is the better adherence and lower risk of different treatment is possible with the once daily dosing, right?
Once daily.
So if you are using a once daily, possibly your adherence is going to be better and the compliance is going to be better. So, but the
Definitely.
choice of frequency for SIT should be discussed with the patient, in my opinion, in the context of his or her symptoms, while ensuring that the optimal daily dose is targeted for maximum symptom relief. So many times, the patients who are symptomatic all the time, they're not very happy. I have been given only once daily dose. Doctor, aapne keval ek hi baar ka dawai diya. What will happen to me, right? The patients are there who say that, Doctor, I am taking many doses. I've got cardiac diseases, hypertension. I'm anyways using our medicine 2 or 3 times a day. So I can, still be very happy using the twice daily doses. I think this is something which is very personal and what we call as personalized medicine, where we should, discuss with the patient. And again, the cost is also very important. The dual therapy, the therapy which is the formoterol based is still, cheaper as compared to the
Cheaper.
once daily dosing therapy.
Vilanterol or intercaterol doses.
Yes. So again, depending on the burden of the patient, the choice of the patient, we can, give the once daily or the twice daily doses of SIT in these patients. Coming to Dr. Anshu once again, asking you something which is again possibly very much personalized to the patient. What is the choice of device in SIT, in your opinion?
Sir, what I believe is that we haven't still been able to, get the best out of most of the molecules, whether it's triple therapy or dual therapy, because of the devices that we have in hand. In fact, if you see just a PMDI or a DPI, the drug deposition, we know it's very hard to exceed 30 to 40% also in a lot of devices. And with COPD being a peripheral lung disease, with the small airways being so much involved, we we would want the delivery to be able to target these airways, the MMAD to be enough to reach these airways. So the ideal device for me definitely will be the one which is able to reach both the small airways and the medium-sized airways. And it because of COPD patients, again, elderly patients, geriatric patients, a device which is easier for them to use. I see so many patients having trouble with inserting the DPI capsule in the DPI inhaler, and most triple therapy that we have now with us is in DPI form. It's only recently that we've had MDIs or breath actuated inhalers also being introduced. So the ideal device should be the one which targets the small airways, which is easier for patient to use, should be and the drug deposition should be definitely high. If you look at the comparison, soft mist inhalers, they have better drug deposition than even a PMDI and a spacer. And when you use a spacer, a chamber is supposed to have a better drug deposition. So, see, we should be looking at devices with a lot of focus on that. Secondly, most devices do not have a stable suspension when these three drugs are concerned. Because if you remember, when glycopyrronium was introduced, it was just introduced as a DPI, and most pharma companies would come back and say that glycopyrronium is not stable enough to be in an MDI formulation. So the stability is also very important. And just like I mentioned in one of my slides, actually the newer technologies, they are looking at co-suspension for less sedimentation, less caking of the drugs. So that's also very, very important when we have a device for SIT.
Thank you, Dr. Anshum. That was very interesting to learn from you. And as you said, there is no ideal device. Again, this has to depend upon the patient choice. Possibly a DPI device, which is breath actuated, may be a more prudent option when the overall benefit is considered. I would just like to know from you about the nebulized therapy of SIT, where there is a company which has got a formoterol budesonide combination and then glycopyrronium combination. They say that you can mix the two together and then it can be used as a SIT therapy twice daily as a nebulized form. What is your opinion on that?
So I think nebulized, open triple nebulized, we've all been using for our sickest of patients. We've been giving glycopyrronium as nebulized form and formoterol budesonide, or together. The stability of glycopyrronium as a triple nebulized form is still not very established, and that is the reason why we still don't have nebulized forms of triple therapy available. And I'm sure the companies are working on that, and they will come up with some technology in the future. That's why most of them have GF or glycopyrronium formoterol together, and the ICS is different because again it is suspension versus solution. The inhaled corticosteroids are in a suspension, they have a heavier molecular weight, and when you mix it with the solution form, the ideal aerosol size that is produced will not be ideal. And glycopyrronium is very mischievous in terms of sedimentation when it's mixed with these molecules. So as of now, we don't have a triple therapy combined nebulized form because of those challenges.
Absolutely right. Wonderful, Dr. Anshum. Thank you so much for this insight. Now, again, my question goes to Dr. Indranil Haldar. So this is a little tricky question, as a matter of fact. So now we're going to talk about the various traits of COPD where the triple therapy can be used. And one of the trait of the COPD patients is who continue to be symptomatic, continue to be breathless, continue to be coughing, but may not be exacerbating frequently, may not be having high eosinophil counts, but they are uncontrolled on dual therapy. What do you think is the role of triple therapy or SIT in these patients?
So Manoj, yes, as Ansu has already highlighted, frequent exacerbator, those with high eosinophil more than 300 are the candidates where steroids in COPD can be given. And the triple therapy definitely will be beneficial in them. But if you see some of the trials, which as Ansu has highlighted, the impact trial, which confirmed that triple therapy significantly reduces the rate of moderate to severe exacerbation in patients with moderate to severe COPD. And it has also shown the triple study group also systematically reviewed shows marked improvement in the health-related quality of life, which was measured by the SGQR score over the 12-month interval. So there are few groups of patients who are really uncontrolled on the dual therapy, showing benefit on triple therapy. I don't know, this may be the subgroup of patients who have a component of asthma, and these are the patients who may be benefited with this steroid therapy. So it is better that some more trials, some more work on this should be done to get out what this real subset of these patients are. Either they have a component of asthma or the previous classification of asthma COPD overlap may be there. So straightforward, the bottom line should be those patients with the exacerbator and eosinophil count high benefit. Patients on dual therapy, but none of this a query. But yes, we have found some benefits from some of these studies and the trial, but maybe that they may have some component of asthma or some overlap syndrome.
Absolutely true, Dr. Anjanil, and wonderful to learn this thing from you. In fact, there are several phase 3 trials which have assessed the safety and efficacy of in COPD patients who are uncontrolled on dual therapy. And in fact, the Canadian guidelines do recommend the role, the triple therapy in this group of patients. It's not mentioned in goal, but Canadian guidelines do recommend that. It will be very interesting to, have some discussion on Canadian COPD guidelines, which seem to be more practical, something that we follow. As a matter of fact, many of us are using, triple therapy in these group of patients. So patient with COPD CAT score of more than 10, maybe one of the patients who continue to be symptomatic despite dual therapy, where the triple therapy can be offered. But in these patients, we should be mindful of how these patients are progressing over a period of time. At least we must see how they're doing over 3 months or 6 months, whether they're improving or not, whether they're developing pneumonia or not. So if they are not improving and they are developing complication like pneumonia, possibly we may stop using the triple therapy in these patients. That would be my take on this.
So it is either the single inhaler triple therapy or the combination of ICS LAMA with LAMA in any way. That's the group of steroid that we want to mean in these patients.
Yes, agreed. So coming to Dr. Parul Bhargama, this is about the non-smoking COPD patients. What do you think is the role of SIT in these group of patients?
Yes, sir. Non-smoker COPD actually is a very important entity, and I have studied so many trials where Indian trials also say that the proportion is quite high, which we many times don't recognize. I would like to just mention the study of our own Dr. Rajendra sir. Today I was going through a couple of trials. They mentioned that it is up to 65% of the COPD. So non-smoker COPD, we have to suspect or we have to detect, even if the patient doesn't have smoking history, but maybe because of indoor pollution, maybe because of biomass fuel, we have to see, and when we do the PFT of such patients, they have more of air trapping and FVC is reduced. FEV1 is definitely reduced, but FVC is also reduced and somewhat restriction is there. And when we do the blood counts of these patients, there are high chances of eosinophilias also. So in short, these patients are a different set of group of patients presenting with a different spirometry and different blood eosinophilia, and where there is an important significance of giving ICS along with the combination of LABA plus LAMA. So definitely I recommend, and the studies also recommend the use of single inhaler triple therapy for especially non-smoker COPD patients, and it is highly effective and it is responding because many of these patients are having eosinophils or the symptoms more or less related to asthma. So this is an entity where we have to first detect. If the patient doesn't have smoking, still we have to suspect non-smoker COPD, which many times we don't suspect, or we don't give attention to that. Yes, smoking is not there, so we don't suspect that it can be non-smoker COPD.
Wonderful. Thank you, Dr. Parul. And I totally agree with you that non-smoking COPD is actually our problem. It's the problem of India. And as you very rightly said that, these patients are likely to benefit from the triple therapy because many of these non-smoking patients possibly have got, coexisting asthma. And you're absolutely right. These patients have a small airway obstruction and the eosinophil counts are quite high in these patients. So this cohort where the patient doesn't have a smoking history and presenting as COPD, possibly it's better to err on treating these patients on a triple therapy rather than a dual therapy. That would be a better idea. But again, we have to be watchful about the risks of pneumonia and how these patients are improving, whether they're improving or not. That remains very, it's very, very important key aspect, as a matter of fact. Now I come back to Dr. Anita Anokar, and she has got a very straightforward question where the role of, SIT in COPD frequent exacerbator is very well established. I would like to, have your view on, role of triple therapy or SIT in COPD frequent exacerbators.
It's already established by all the studies, like all the trials that are done for the triple inhalers. Like we established that like in a patient who is moderate to severe, that it helps in first reduction in exacerbation, improves in lung function, and reduction in overall hospitalization rate. So there is definite role in reduction in exacerbations. But then when to start the triple drug in a patient first presenting with the exacerbation, that is something a controversial thing. Like Dr. Anshum has already mentioned, like there is one study from UK where they have stated like to start it at the time of discharge when the patient first comes with the severe exacerbation. So at that time, and if there is delay, like if it is not started during that period, then it can further worsen and it may not reduce the overall mortality if it is delayed. So, but like again, I will come back to the same thing. Like first, we need to take into consideration about the patient inhaler technique, whether patient is able to take that, because most of our initial inhalers like with the triple drug are dry powder inhalers which require a specific flow rate to get the proper deposition, and now few are available like recently with the meter dose inhalers. So in those patients where you expect that patient will be able to take it and you like take the inhaler technique into consideration, then at the time of discharge you can start, or if not, then you can give that trial or at home nebulization, and then obviously reconsider it when patient comes for follow-up. So in case of exacerbation, there is definite role in reduction.
What about Dr. Anita in patients who are frequent exacerbator, but the eosinophil count is less than 100? What about
So
this?
in those cases, yes, sir. That is definitely one group where like we are talking about the type 2 inflammation or blood eosinophil count or sputum eosinophil, where it will help definitely. Those patients who are, despite like the treatment, they are frequently coming with exacerbations and not responding. So in those patients, first like our goes back to adherence to the treatment, whether they are adherent to treatment, whether they are properly inhaler technique is device, whatever you want to change based on that, the compliance and deposition. Take into consideration other factors if it is not a drug, but definitely it is something optimal treatment that we have already started the patient on, and you can take care of other factors like vaccination and other things to find out how we can help them in a better way.
Wonderful, Dr. Anita. In fact, we were all focusing on eosinophil frequent exacerbator, but we definitely have to look into the various causes of exacerbation, which is very important. Most of the time, it is a patient-oriented, or we have not addressed their issues of managing their inhalation technique appropriately. So that is the first step that we have to look into before thinking about using triple therapy or whatnot. So wonderful, Dr. Anita Nukar, and thank you so much for that.
Yes.
Now, I would like to come back to Dr. Prem Anand. We talk of the lung function test, and as a matter of fact, our guidelines do not include the lung function for deciding our line of treatment, as well as the pharmacological line of treatment, whether it's a dual therapy or triple therapy. Right? It all depends upon how symptomatic the patient and how frequently is exacerbating. So there is no role of the lung functions, the FEV1, as a matter of fact, in the management of these patients. But we have a group of patients who are rapid decliner in the lung function. Right. What do you think is the role of SIT in COPD patient with rapid lung function decline?
Of all the COPD phenotypes, definitely rapid decliners, frequent exacerbators, non-smoking COPD, ACOS, there are high chances of exacerbation. And out of 100 COPD patients, if you take 30% of patients tend to have a rapid decline in lung function. And it is also more pronounced in COPD patients with late onset asthma development also. So as per studies, it has been proven that 1/3 of the COPD patients are at rapid decline of lung function. And as per some study like fulfill all those things, it has been found that the patient has been put up on triple therapy. Rapid decline in lung function is seen, but it is 25%. But whereas when the patient is getting dual therapy, it is 50%. So in that way also it is better. And time to clinically significant or deterioration, when the patients are put up on SIT, the time for the clinically deterioration symptom, that is the first episode, it is almost 5 times longer in when the patient is having SIT. But whereas when compared to dual therapy, it is much more shorter period. So in all those supportive evidences, it's better to go for, and what I feel is, even as per the guidelines, definitely rapid decliners are the subset or phenotype of patients who should be carefully picked up and put upon SIT therapy after enough counseling, etc. Because the guidelines doesn't suggest lung function, all those things, but still we have to follow them aggressively.
Yes,
And
thank
they
you,
are the
Dr.
one who present with emphysematous type.
Absolutely. I totally agree with Dr. Prem. And, it's very well known that the lower the FE1, the more rapid decline in lung function, more the chance the patient would like left with the exacerbation. So this is a group that we have to be carefully watching out. And if this is happening, possibly this is one of the candidates where the triple therapy can be considered. Now, coming back to Dr. Anshu, echo. A little controversial topic. We do not have a definite diagnosis what the echo is all about. The gold has already dumped it. Gina continues to be there with echo, and it is believed that echo is nothing but an asthma with a COPD component. So what do you think is the role of SIT in COPD with the history of echo?
So firstly, I am a believer that ACO actually is an entity that we have to be really worried about, because large population of our asthmatics are smokers, and they will develop COPD in a certain point of time. So this entity actually does exist. We have COPDs with asthma as a background, and the diagnosis is not certain, because we don't know whether we should attribute these symptoms to asthma or COPD. So firstly, we do see this phenotype and this entity, and because asthma is associated with eosinophilic inflammation in a large population, so these patients are super responders to ICS. So when we talk about ACO or COPD-A, so gold guidelines, I think, have very smartly given a new name, because they didn't want to go back to the term. So COPD-A, as they would call it. So they will be very good responders to ICS. So for me, what I believe is that if we have to give SIT in a patient with COPD-A, here the ICS strength or the dose of ICS has to be given a lot of importance, much more than the LAMA strength. And as I showed you in my slide, where I've actually noted down the strengths of individual combinations in India, you would see that the combination that's actually approved for asthma in India has LAMA as a very high strength. Glycopyrronium is 63.5, and ICS is only 160 indicatrol, is 160 microgram. But when we are looking at asthma COPD overlap, we know they'll respond very well to ICS. So the ICS composition should be definitely higher or better as compared to more of LAMA. So what I feel is that we need a triple therapy with ICS there as playing an important role. So in this case, entity of people who are smoker asthmatics, or asthmatics who with time have had the remodeling of the airways and are now developed COPD, they would be the group that we'll be looking at.
Thank you, Dr. Anshum. A very interesting insight from you. And just want to know from you, would you ever de-escalate SIT in these patients to dual therapy, or maybe you want to remove the LAMA from these patients?
So I think these would be the ideal people who might be continued on triple therapy rather than de-escalating. Because as in an asthmatic, we would not want to continue LABA LAMA alone without an ICS. So these would be the perfect candidates who would continue on triple therapy rather than think of de-escalating. Maybe the strength of ICS, again, we are lucky to have many compositions. Maybe we'll be able to titrate it in the single inhaler itself with an inhaler with a lesser ICS dose if the patient is comfortable, and a lesser dose of the LAMA. But I would not take them off the triple
Come
therapy.
back to the doses of ICS or the various combinations that we have in our country. We'll come back to it. But very important is from you that we have to use higher dose of ICS. Very important. It's very important that we use a higher dose of ICS in patients of echo, which is extremely important. The lesser dose, say, 200 microgram twice daily may not be sufficient in these patients. Now, coming back to Dr. Indranil Haldar. So basically, we are focusing on the SIT therapy and COPD patients, as a matter of fact. But for the benefit of our viewers and listeners, I would like to touch upon the uncontrolled asthma and optimal ICS LABA. What do you think is the role in these group of patients? Just a brief opinion from you, Dr. Indranil.
So, Manoj, as Ansu really highlighted on the COPD, but yes, in asthma also, the triple therapy has its role. And if you see, there are a few number of trials. Just I can recall a couple of trials, which was the Symphony trial, the Realist trial. And if I just highlight the Symphony trial, the trial demonstrated there a remarkable 35% reduction in the exacerbation among patients who are using the SIT therapy to standard therapy, which means ICS LABA and SOS SABA, or standard therapy means ICS LABA and SOS ICS LABA again. So not only that, if you see the Symphony trial, which it highlighted the SIT therapy in asthma, there was additional improvement in patient-reported outcome was noted. That is particularly in the asthma control questionnaire and asthma quality of life questionnaire score. So it was important. So the quality of life, the exacerbation, all were decreased. So the Realist study also provide further evidence of real-world evidence of this SIT therapy in asthma. There were lesser severe exacerbation, fewer emergency departmental visit. So definitely we can tell that there is a therapeutic advantage of this SIT in achieving better asthma control and overall wellness in patients who are on standard therapy and poorly controlled. So it may be a promising strategy for managing uncontrolled asthma patient, but again, more number of studies are required.
Thank you, Dr. Indranil. And I would just like to add to it that in fact, what we mean by triple therapy in asthma is that we are adding LAMA to the ICS LABA combination. And before you add LAMA, it's very important that you double the dose of ICS in these patients. And only after the patients where the higher dose of ICS has been given and they remain uncontrolled and they present with frequent exacerbation, then the LAMA is added. Is that right, Dr. Indranil?
Yes. Yes.
Yeah. So that's very important, message for our listeners, that you just don't add LAMA to ICS LABA with the usual combination. You have to use a higher dose of ICS LAMA first, ICS first. And then if you see that this combination not working, then only the LAMA has to be added. Sorry for...
Absolutely true.
Thank you. So thanks once again, Dr. Indranil, for, giving an elaborate view on the uncontrolled asthma, where triple therapy has a very important role to play, as a matter of fact. The important thing is it improves the symptom control in this patient, the triple therapy. But whether it improves the mortality outcome in asthma patients is really not established. That is something that we have to be bearing in our mind. Now, coming back to Dr. Parul. Now, Dr. Parul, we are very fortunate, as Dr. Anshul said, that we have various combinations of SIT available in our country, as a matter of fact. Okay. So how do you compare various SIT combination in terms of efficacy and safety? Do you think there is one combination which is superior to the other one? What is your opinion?
I think it is one of the, I would say it is still to be studied question. But yes, I will put all the facts in front of the house. See, we all know that which are the available SITT in India. We know the molecule Vilantrol with fluticasone with umeclinidium, formoterol budesonide or beclomethasone with glycopyrrolium, indagatrol with memetazone and glycopyrrolium, and Vilantrol, fluticasone and glycopyrrolium. So there have been many trials and there have been bigger meta-analysis also. and which says that in most of the meta-analysis, it tells that vilantrol with fluticasone with umedclinidium with comparison with formoterol, beclomethasone, and glycopyrrolate combination, it says that it is somewhat superior. But at the same time, we have many meta-analysis and Indian trials also. And one of the trial is from our own Sandeep Salvi sir also. And there are so many other trials also, which tell that vilantrol with fluticasone and umeclidinium is comparable to formoterol, budesonide, and glycopyrrolate. So point is that overall, there have been many studies showing superiority, but there is no much difference in the FEV1 values. There is no much difference in the improvement in the exacerbation, and there is no significant difference in the adverse drug reactions. So my point of understanding from all this meta-analysis, which is published in 2022, 2021, and it is in the open journal as an open journal, and it has been internationally studied that these newer molecules, vilantrol, fluticasone, and umediclinium, may be superior in some set of patients. But overall, these two combinations, which are mostly studied, other two are not mostly, the other two are not much studied, but we still need many more trials to conclude that which combination is a better combination for a group of patients. But Indian trials, 2-3 Indian trials I have seen, and they say that it is moreover similar. That is my take from these different trials.
Yes, and one area of trial would be to compare the single once daily dose and the twice daily dose. This is something which again has to be studied. But let me put you one question straightforward to you. Which is the sit that you use? How do you choose your sit? Dr. Parul?
So we choose on the basis of our patient clinical, obviously the exacerbations, the FEV1 value, and number of exacerbations per year. But what we are recently choosing in our OPD, we are giving majority of the patients, we are giving vilantrol with fluticasone with mediclinium. But at the same time, we have so many patients already put on formoterol, beclomethasone, and glycopyrrolate combination, and they are doing well. So, sir, we are happy with this. We have more patients on formoterol, budesonide, and glycopyrrolate, and they are doing well. And every 6 months we repeat PFT, which is really improving. So clinically, if I stop, I have almost 100 to 120 patients of COPD every day. So clinically, we are not finding any difference yet, but still, sir, it is, I think there are so many trials which are putting that vilantrol molecule combination is better, but still it is needed. It needs to be studied more. That is my submission.
Ask you a different perspective, Dr. Parul. Suppose your patient is on a combination of budesonide and formoterol, and he's not doing well. Now you want to give a sit to this patient. Would you add on, maybe glycopyrrolate, all this, or you would change the entire sit combination of this patient? Maybe you go on to fluticasone and, umeclidinium and glycopyrrolate, whatever, or vilantrol. So what do you ever consider this kind of thing in your practice? Change the whole.
Yes, sir. So if my patient is on formoterol or budesonide or formoterol, which usually is formoterol, budesonide, or formoterol, beclomethasone, sir, I think we will add on to this patient to first glycopyrrolate combination, which will be triple drug therapy, of course, triple drug, single day, single inhaler therapy. We'll watch this patient for 2-3 months, and then we will think of shifting to the new molecules. This is our routine practice in the most of the setups of government, or where you have number of patients and limited resources. But yes, I would like to continue with these molecules first, add on the first third molecule, and continue it as a single therapy.
So that was the question,
But again, it is
out of my interest, as a matter of fact, something which comes in my mind, whether should I change completely or maybe add one more molecule to it. Same question again goes to Dr.
But
Anita.
singles are just a summation. We all know that single therapy is always effective, more effective. Most of the times it is effective, as it is increasing the adherence and also minimizing the complications of the therapy. So that message we have already given in the talk by Madam, Dr. Anshul Madam, so I have not repeated. But yes, molecule adding and making it single triple drug therapy with these molecules is more important.
Yeah, that sounds good. I mean, there is no harm in adding a single molecule. Possibly, you can also change the entire combination. So again, it's an individual choice. Possibly something to look at also, something matter of research possibly in future. Now coming back to Dr. Anita Anukar's almost similar questions. What are the different available combinations in India, and what is your experience, Dr. Anita, with these combinations?
Yes, so already like it is stated, like we have the same combinations like most commonly available and that we say the pocket friendly, like less cost and our patients, and that is the reason for wide use, like that is started with formoterol glyco and budesonide. So the other combination which is like we consider as a more costlier, that is umeclidium with mometasone. So that is not, we haven't like that routinely used. So my experience on that will be little less than I think the other people might have used it. But considering with the this twice a day dosing of formoterol glyco and budesonide, I think most of the patients are getting better cover on that. And like you had already mentioned about that early morning symptoms or late nightening worsening will be taken care by those two doses. So additionally, it is a better thing. So other molecules, like I think like we are going to have in pipeline about that aerosphere and other things, that will be a better deposition. In that case, like I think that is better to have for the better deposition and all, and we should be trying once the patient is stable. So point to consider from changing one inhaler to other inhaler, like from twice a day to once a day. I will not change it when the patient is in exacerbation or not controlled. I'll find out other factors like increase the doses or cover with something oral steroid, let him have the better control, and then might you can switch from twice a day dosing to the single inhaler. And on that, just find out for a few months whether he will be stable on that or not. So that I'll consider before changing.
Thank you, Dr. Anita. And once again, as you reiterated earlier, it is not the combination, it is how the patient takes it. Whether what is the inhalation technique is going to be more important than the combination that you use as possibly at this point of time. Now coming to Dr. Prem Anand, so we have discussed that various SIT combinations are available in India, but if you look at these combinations, the doses, you got a combination where the mometasone is available in dose of 160 rather than 320. Then there is another combination with the fluticasone is available in a dose of 100 rather than 200. And all these trials have shown that it is a higher dose of ICS, which has really changed the outcome of these patients. So do you agree with, or are you happy with the dose of SIT combination that is available in India, Dr. Premnath?
So we have multiple combinations. If we take formoterol, we have at one hand, we have formoterol 12 microgram with fluticasone 250 with glycopyrronium 12. On the other side, we have formoterol 12, budesonide 400 with glycopyrronium 25. This is one subset. On the other side, we have indicator base. We have two combinations already, two different combinations. Combinations is the same, but strength is different, 150, 50, and 50. And we have umeclidine base separately, which is more costly. So among all these things, what the final comfort with the patient is, and we all well aware that though ICS is it may have a chance of pneumonia around 1 to 4% as a whole, it may be much useful in patients with asthma or asthma overlap is ECOS. So when it comes to COPD management, what I feel is the lower the ICS, the more the better. Anyway, at a point of time when they go for a deterioration or exacerbation, they may be hospitalized with a systemic steroid.
Right.
And we have only one study in India by Salvi sir, which has proven, which has mentioned that there is not much difference between the available combinations, even when comparing the multiple combinations available, like formoterol based or vilanterol based, etc.
Absolutely, Dr. Prerna, that's wonderful. I would just pass on this question again to Dr. Anshum. Are you happy with the doses of SIT combination available in India, and what is the ideal SIT combination, Dr. Anshum? I would like to know from you also.
So I think dosages, as you just said, we have a variety of dosages, and some combinations actually, especially the DPIs, have budesonide even to the tune of 400, and we have formoterol 12 micrograms with glycopyrronium 25, and they are perfect for a BD dosaging. I would differ from giving a budesonide of 200 and formoterol of 6 and a glycopyrronium of 12.5 to a patient who's already not controlled, and that's why I'm stepping up the treatment. And in that case, maybe I can step up to 2 capsules of the DPI twice a day, or if it's an MDI. But I've seen that DPIs have a higher strength as compared to MDIs in all the formulations. For me, an ideal sit, I also prefer actually BD dosaging in COPDs per se, because I've seen that COPD patients, no matter what combination you give, they do complain of diurnal symptoms. And choosing a rescue becomes a big task when we are giving single inhaler triple therapy, because we can't titrate it truly and it's a fixed dose. So I usually prefer BD rather than OD, except if the patient is absolutely stable, and that I would do once he's stable on triple therapy, and then I can tell him that now you can take triple therapy as once a day because it's working well for you. So for me, an ideal combination should be definitely an ultra long acting drug. But the dose of ICS, and even the ethos trial had shown that, they had compared 2 doses of ICS, and compared to 160 and 320 microgram of budesonide, the mortality benefit and all the benefits were slightly higher in the 320 group compared to 160. So although the difference is still much, much better than LABA-LAMA, but amongst the dosages also, the higher dose had a better this thing. So if it's an uncontrolled patient, I would have to give a higher dose. But once the patient is better, maybe the lower strength dose of ICS, that combination becomes the ideal one for that patient.
Dr. Anshuman, I think this is a very important message. The dosing of ICS is extremely important. Do not underdose them. Ultimately, that's not going to work possibly in these patients. So that's wonderful, Dr. Anshul. Thank you so much. Now, ours is a resource-constrained, country, and we always look at the cost. We look at the quality, but more than quality, many times we look at the cost. So the discussion is always there as far as the cost is concerned between SIT and MIT. And I think Dr. Anil Haldar will throw a light on the cost issues between the SIT and MIT.
Okay, Manoj, first I'll be telling the bottom line. Bottom line is definitely the SIT is cost effective. Just do the calculation. If you see a triple therapy SIT, the average cost of therapy, be it PMDI or a DPI. So we have India, what we are telling. In India, we are fortunate. We are telling about the dosage, the right dosage, whether we are satisfied or not. We have a variety of dosage in India. We are fortunate for that. So just take one example. If I take this SIT, be it PMDI or MDI, the average cost of therapy comes to about 900 rupees to 950 rupees. Just divide it in.
So you're muted.
Sorry. Am I right now? Am I audible? So what I was telling is that in India, we are fortunate that we are having a lot of combinations, and that is right. So if I think of the PMDI or the DPI, whatever the choice, the bottom line is the SIT therapy is cheaper. Just take an example. If I think of the PMDI, the SIT will cost in and around 900 rupees. But when it is divided between the multiple inhalers, the cost comes to more than 1,550 or 1,100 rupees like that. So whatever it is in the DPI or the PMDI, the DPI, I think is a bit costlier than the PMDI in the terms of 100 or 150 rupees. So the bottom line is SIT is cheaper.
I totally agree with you. In fact, SIT may appear a little costlier than the MIT, but as a matter of fact, if you look at the indirect cost, the cost of, exacerbation, which is involved in the management of these patients, plus increased morbidity and maybe a risk of mortality, I think cost should not be the issue. It is the quality that should be the issue. And if the patient deserves a SIT, it's better to give SIT to the patient. That would be the right approach. Now, coming back to Dr. Parul again, we have talked a lot about SIT, and we think that SIT is the gold standard now. Dr. Anshum also said all that the gold that deters is not gold. So, would you please tell our viewers what would the indication of using MIT instead of using SIT in patients COPD?
Yes, sir. As we have already discussed in throughout the talk and throughout the discussion, and all the trials tell that single therapy, single multiple inhaler therapy is good. But what we have seen clinically, and also somewhere we have some of the guidelines tell that, if sometimes what happens, you have the dosages definitely. For example, formoterol, budesonide, and glycopyrrolate. In some of the patients, you may get some of the more need. Means if patient is needing more inhaled steroids or other drug which is required in the more dose, or maybe there is some side effect due to particular drug. In certain conditions, we have to modify the dose or we have to go for the multiple inhaled therapy. Many a times we have felt that night symptoms or early morning symptoms are also not controlled. So in such cases, we can go for the multiple therapy. With these same molecules, it gives more effect. As Anshu ma'am told that BD dosing is preferable. In fact, in our practice also, we give BD dose, and we are finding that BD dose is giving more control, especially night symptoms and early morning symptoms. So my point is that when my patient is having a need of in ICS, which is much more, maybe more than 400, or maybe more than 200, or maybe any molecule which where I feel that my patient needs more ICS, then I will definitely add on ICS as a separate inhaler also in such patients. And if I feel that yes, this patient needs more formoterol, then also I can give the combination of that as an additional inhaler. So it depends clinical improvement, my patient follow up after 1 month or 3 months, and of course the patient having night symptoms or early symptoms, which should be tightly controlled. If we are using this 3 molecules, at least we have to give good control. So in those conditions only we will give multiple therapies. Otherwise, most of my patients I treat with single. But there are patients, especially patients who are in moderate to severe COPD, who are having frequent exacerbations. Sometimes they are having overlap symptoms. The overlap is now like outdated word, but still there are patients who are having COPD and asthmatic symptoms also. In such patients, clinically, we have to use multiple inhalers to give a tight control and to give a better night symptoms and better early morning symptoms and quality of life. So there are certain different patients. In such patients, we use multiple inhalers.
Thank you, Dr. Paro. That was wonderful. And just to summarize it, somebody who has got frequent symptoms, who is, more symptomatic or exacerbating possibly in those patients, it would be a good idea. Now, coming to Dr. Anita. Now, these patients are requiring, who are on SIT, or, maybe on once daily dose or twice daily dose. Now, if these patients develop exacerbation or they have become symptomatic, they develop symptom of breathing difficulty or increased cough, and you want to give a reliever or rescue medicine in these patients, so what would be the choice of reliever in patients who are already on SIT?
So actually that is something like we have come from like rescue medication all the time to the smart therapy, like that is single inhaler, like maintenance and reliever. That is the same combination that is available for formoterol budesonide. So that has brought down the use of rescue medication in most of the cases. So if you are using the same combination, so that is something called a smart to smarty, like that is smart in addition to triple inhaler. So that is already taken care by. So those people already having less exacerbation and having proper symptom control, so may not as such will require most of the time the reliever medication. But in the other group, like where we have the other category where we are using other combination other than formoterol, like other indicatorol with imeclidine and other molecules. So there we may require, and we should not be like taking the patient for granted for not using it, because even if we don't prescribe, they may be using those multiple inhalers when they are symptomatic. So properly need to advise and counsel the patient about what symptoms like they need to take into consideration, the timing of medication after checking the inhaler techniques and all, and prescribe the SABA can be prescribed as a rescue medication in those cases. That I think I will do that.
So wonderful, Dr. Anita. And what you talked about, the smart therapy is basically for asthma patients. So those who have got asthmatic COPD, possibly the smart therapy, you use a combination of ICS and LABA as a rescue therapy. But in patients of COPD, pure COPD, who are on SIT, possibly we may only use a bronchodilator, maybe a LABA or a combination. What do you think about that? The LABA LAMA may not be the right choice. Maybe the SAMA and
Yeah, that's what that
the right choice. Yeah.
So Manoj, what I think,
Yeah.
Manoj, what I think the bottom line for every rescue, if you are using a seat, should be a Saba. That's the ideal choice that should be. Or because again, you are using all of these combinations, and be it in of course in COPD and also in asthma, when you are using a seat, the rescue should be a Saba in that way.
Why do you say that, Dr. Indranil? Why? What is the point
So
behind
again,
it?
so if you think
Especially if the patient got an asthma.
so if even the patient is getting an asthma, the asthma, all the trials or all the guidelines that are focusing, so the smart therapy should be only on patients who are using ICS that with a formoterol, that is budesonide with a formoterol combination. That should be what the guideline speaks of. If you're using something other than that and using a rescue medication, the rescue medication should be a SAVA in that way. That's my option
I,
in.
yeah, I agree
Yeah.
with sir. A Saba or a Sama can be, or a Saba Sama could be the, I mean, at the most the rescue,
Again,
because
you are using a long-acting
yes,
anticholinergic.
and I'll,
Using a long-acting anticholinergic, and you are giving a short-acting anticholinergic to a patient will be not science in that way. For a COPD patient, if you are giving a ICS with a SABA or a ICS with a formoterol combination, that also you are using higher dose of steroid to this patient. So in that way, when a patient is getting sick, be it because of COPD or because of poorly controlled asthma, who are on triple therapy, where dual therapy or normal conventional regime is not working, then I think that the SABA should be a choice.
So even I agree to this, sir. Even we are doing it routinely also in our practice. We are giving one SABA for night symptom control and early morning symptom. It is working well with triple drug therapy.
Absolutely. But if you look at the GINA guidelines, somebody who's in a combination of other than formoterol and budesonide maybe give a combination of beclomethasone and formoterol as a rescue therapy. But the point is very well taken. Possibly a patient who is on a higher dose of inhaled corticosteroid, who is having exacerbation, even though he's a patient with asthma, possibly a steroid-resistant patient. And that patient, possibly, if you're adding ICS again as a rescue therapy, it may harm the patient more. So it's a very interesting discussion, as a matter of fact, looking at various aspects, various permutations in the management of these patients. That's why this field is very, very exciting at this point of time.
and so purely if you look at just a COPD on triple therapy, there's enough data to show that if you have overdosed the ICS, the infections and the pneumonias will exponentially go up. So if we are using only an ICS LABA also, a triple therapy we cannot use it smart for sure, because we'll overdose glycopyrronium also, which will be a big hazard. But if you're thinking of using an ICS LABA also, then we are overdosing it enough. So that's not recommended. A SABA will be a quick acting.
That's the thing. If you are using an ICS LABA, that should be formoterol combination. And you are using overdose of steroid, which will increase the chances of pneumonia, which is not required in COPD.
Yeah.
So most of the trial in triple therapy are in COPD or in asthma, which are very poorly controlled even with conventional therapy. So in this patient, definitely we should not be pushing too much of steroids in those patients, at least in COPD. And in asthma, again, we have to have a combination of that with that. But it is better for a patient to carry a SABA along with the triple therapy than carrying another ICS LABA in patients. And you cannot be sure that this patient is really a patient of asthma whom we are giving triple therapy. Probably they have been converted to fixed airway remodeling or the COPD-A, as you already mentioned.
Very well said. And as the panelists have agreed that as a matter of practice, if somebody is going to sit, I think the idea should be that the patient should be used maybe just a SABA that is good enough as a rescue therapy. So thank Dr. Indradil and Dr. Anita and Dr. Anshu for this insight. Now I come to Dr. Prem Anand again. So when we talk of the trial conditions, people criticize, this has been under trial and, it may not have a value in the real world. So a lot of, talk is going about the real world scenario, as a matter of fact, how a combination is working real world. So what is your take on real world versus trial experience with SIT, Dr. Premanand, in COPD management?
Real versus trial will maybe classified whether we are using it for asthma or COPD. But as per article published in European Respiratory Journal 2019, when you use SITT, it has been found in Western world, it has been found that India is not covered in that study. Western countries are covered. It has been found that 80% of the adherence was more than 80%. That is, the PDCs around proportion of days covered is more with SIT group, definitely comparing to MITT. And head to head, when you compare SIT and MED, adherence, persistence, the time to clinical iteration, everything is less with SIT. But when we take our own patients, when you put them upon SIT, for example, if you're taking an asthmatic patient, they're initially very happy, but once they go for exacerbation, they come and mention that the previous inhaler which you had given 1 or 2 years ago, which was twice a day usage, is much better in such a way that I was able to use it during exacerbation also. Because the Belantrol base, Intercatrol base, they provide a good control, but when they go for exacerbation, it's same with COPD also. They're not able to cope up with the single dosage. So as previously mentioned, they come and ask for either SIT-based triple therapy or go back to LABA ICS with LAMA-based combinations. These are the
Yes, that's right, Doctor.
real-time experience from the COPD patients whom I have treated.
Yes, so I totally agree with Dr. Prem Anand, and the real world scenario also has shown that the triple therapy is superior to the MIT. The SIT is superior to MIT, so that remains perhaps the ideal at this point of time.
Ideal.
So when you're thinking of using a triple therapy, it's better to use a SIT rather than MIT. So we totally agree with you with that. So coming to my last question in this panel. That is to Dr. Anshum to conclude. And Dr. Anshum, do you find any gaps in the SIT, and what do you think are the future prospects of SIT in the management of obstructive airway disease?
And I think the gaps that still exist are that we still don't know, as Dr. Parul was mentioning, head to head, direct, head on. We don't have RCTs to say which one is better. It's still adding to a lot of confusion. We would preferably have a lot of clarity on that in the future. Which combination of SIT would be better in which population? I still think that delivering SIT in a conventional device is not the way forward. We want better drug deposition. So the future prospect is one universal device probably, which would have all these formulations. And thirdly, nebulization. SIT in nebulization, because we know a lot of our COPDs who are very severe end up having home nebulizations. So we would see that in future we will have nebulization with SIT. And there are new molecules in the pipeline. Olodaterol is being studied again as SIT, as LABA-LAMA also. So we may see more combinations with that also.
Dr. Indranil, you want to add?
It's absolutely. Ansu has summarized it very well. But Mono, just to ask you a question, there are a number of combinations, permutation combination of SIT that is available in the market. Just your opinion, where is the one that we normally use is formoterol budesonide glycopyridinium in the dose that Ansu has mentioned, that in the dose of PMDI or DPI, if you are using the PMDI 200 or the DPI 400, it's okay. But where do you really find this molecule, bilantrol fluticasone with glycopyridinium, in your practice in patients with COPD or even in patients who are uncontrolled with asthma? So when do you choose bilantrol fluticasone glycopyridinium versus formoterol budesonide glycopyridinium?
Honestly speaking, there is no such choice, as a matter of fact.
Except the cardiotoxicity part. Cardiotoxicity part, or there is a much of tremors where...
Yeah, possibly that could be one thing where the company, they claim that with Vilantrol the cardiac complications, the tremors are less. Possibly that could be the reason, but I really honestly don't have any such choice. I change when the one combination is not working. So patient who has been on budesonide, formoterol, and glycopyridinium, verify this is not working, I'll switch to the other combination. So that would be the time when I really switch. So I honestly don't have such preference, as a matter of fact, for one molecule or the other.
Anyone
I
of us?
have one question. Yeah, so I just want to ask, like when we are talking about MIT versus SIT, multiple drug doses, like inhalers, like that is considering the ICS LABA plus addition of LAMA separately. So like we know all the benefits of SIT already, but in which cases, like where to consider when we want to add LAMA as a separate, considering the adverse effect of LAMA in few patients, like elderly having dryness as a major complaint where they don't tolerate at all. So in those patients, we need to reconsider, even if the patient is started on SIT and having the major complication of dryness that is troublesome, then you can obviously then split up again and give the retrial with the lower doses of LAMA. Like in those cases that I just wanted to add.
In that case, so suppose the
Side
patient comes
effects.
with the glycopyrrhenium, I may go ahead with the tiotrope, and then in those cases, again, the choice will be different.
Yeah, but that
So,
is not there in SIT. Okay, that is there in only the Triohel and Premium, that is like single tray. Yes.
there are many clinical aspects involved, when we managing these patients, as a matter of fact. So many of times we have switched from SIT to MIT. Suppose the patient has not been benefiting with SIT, as a matter of fact. Of course, the trials would say, the SIT is superior than MIT. But you find my patient not doing well on a SIT, I would rather like to split it, right, and see what is happening. So these kind of combinations go on. And Dr. Anshumino criticized about the nebulized therapy. Practically speaking, we may have to go on to nebulized therapy in patients who are not comfortable in using the DPI or MDI, right?
Okay.
And there you are
Yes.
really not sure whether the patient is going to take the inhalation therapy. What might be the precipitation and other things. I mean, we can use them not mixing together, but maybe separately we can use them. So still the nebulized therapy in patients COPD, we're going to pour FE1. Possibly in some patients who are not controlled. Possibly nebulized therapy is an option.
But yes, we are doing that. In fact, not in a single nebulized respues, but we are doing that. For example, ICS lava and glycopyrrhenium are available, and we are doing that regularly in our ward. But yes, not in a single rescue that we are seeing.
And
Not
I'll add,
single rescues.
yeah, and I'll add that SIT versus MIT, the biggest benefit that has come out of all the studies, all the trials is compliance, compliance, compliance.
Absolutely. So
It
compliance.
will also, there are trials, and like the Trinity I mentioned, that have tried to look whether there's an extra benefit, extra synergy with 3 in a 1 versus 2 different. It's the compliance that wins there because patient is comfortable. If your patient is comfortable with separate open triple, it's still triple and it will still give the benefit, I
But
think.
compliance with nebulization is much better than compliance with inhalation, because
Absolutely.
nebulization, they are given by a caregiver or given in an institutional base, or they are really bad patients, and the compliance with nebulization is always good. That's very true.
Yeah. And
So
COVID,
moderate to severe COPD patients, we are routinely using nebulization. It is just wonderful. Though multiple therapies we are giving and multiple monitored therapies we are giving, but we are using nebulization of all these molecules in different
Absolutely.
ways and different patients. And it is really giving very good effect. So I think we need nebulization, no doubt, in one rescue, but it still we have the experience of treating these patients, and it's really good.
So I think we have run out of the time, and I
We have
look
run
at
out of time, Manoj.
yeah, so in the chat box, there are several questions, but I think we have addressed all those questions.
Yes.
So just to conclude, obstructive airway disease remains an important cause of mortality and morbidity with significant healthcare burden, as we have just discussed. SIT is now becoming an important treatment modality in obstructive airway disease management, as it reduces exacerbations, improves symptom control, and improves quality of life. Evidence suggests that improved adherence with SIT is extremely important. And this is one of the important aspects of the management of patients with obstructive airway disease, where the adherence is the key for the appropriate control of the disease. The duration of SIT administration is often based on clinical judgment, and there can be inter-individual differences in this aspect. In the COPD setting, as we discussed, the triple therapy is significantly associated with lower all-cause mortality than the dual therapy. However, the survival benefit of SIT in the asthma setting are yet to be determined. With this, I thank all my eminent panelists, Dr. Indranin Haldar, Dr. Parul Vadgama, Dr. Anita Anokar, and Dr. Prem Anand, and my eminent speaker, Dr. Anshu Maneja Arora. My heart goes out to all of you for such a wonderful session, and it has been a great learning experience for me personally. I once again thank the ICS committee, the lead of Dr. Sandeep Salvi, Dr. Rajadhar, whom we wish a speedy recovery from a nasty accident, and our champion, Dr. Anita Nene. And I once again invite all of you to come participate and enjoy NAPCON 2024 at Pune, which is going to be a blockbuster. With this, I also like to thank the organizer of this event, the Emejika and Aditi Vaidya, for providing all this excellent support. So with this, I end today's session and wish you a good night. Namaskar, Shubh Ratri, Shabba Khair, Sat Sri Akal. Thank you very much.
Thank you, sir. And we
Thank you.
well,
Thank
we
you
are
very
like
much.
the NAPCON preparations are going in full force in Pune, and we wish to see all of you there, like here in Pune.
Good
Yes,
night.
Thank you.
Thank you so much.
Thank you, sir.
Good night.
Thanks, sir.
So we are offline?
Yes.
We're offline. Thank you. Thank you.